Is my screen is visible? Fine, so let's start. Good morning, everyone. Sorry for a little couple of minutes late. I was in emergency room, so sorry for that. So let's start without wasting the time. So once again, welcome all on the same medical MCQ for all. As you know, we are conducting every Sunday classes. So by default, you feel free to join. It's all high yield questions and every time different questions. So I'm just keeping the introductions of all our team. Later on, we will do it. We'll just start with the MCQ first, then we'll have a feedback, and then lastly, I'll guide you a little bit more for the exams as well. So without wasting the time, first questions in front of our screen. A 57-year-old woman who underwent emergent cholecystectomy for a perforated gallbladder 3 days prior. Now she has a fever of 103 Fahrenheit and complaining of chills. Uh, the patient has not been ambulating and says she is a great deal of pain at her incision. What is the most likely cause of the fever? Atelectasis, UTI, that is urinary tract infection, wound infection, deep vein thrombosis, or abscess. So you take your time. I'm today gonna discuss all absolute high yield points and the things with you as usual, right? So you can let people to answer the things well, right? Probably it's just you need to know the cause of post-op fever, right? So post-op fever, you if you know the post-op fever, right? You little get the idea. Yes. I'll give you 1 minute for everyone to have little time for the answer, right? Yes, anyone wants to comment on this? Anyone wants to comment?
B, sir, UTA.
UTI. Okay, fine. So can you little bit explain me why you selected UTI? What are the, I mean, time frame for this post-op fever? Do you have any idea?
Sir, because the cholecystectomy has been done 3 days back, so most probably UTA.
So most
Atelectasis,
probably UTI. Fair
yeah.
enough. So now can you tell me what happens if the fever post-op develop on day one, day three, day
On
five, day
day
six?
one,
Ten.
atelectasis,
Okay, day one is atelectasis.
yeah.
Okay, what else? If develop on day three,
Day three, UTA,
day three UTI. Okay,
and
day seven,
day seven, wound infection,
day seven wound infections. Okay, day 14,
um,
day 14, 1 4,
abscess.
14 abscess. Okay, great. So how did you remember? I mean, overall. So now let me tell you the real these things. This cartoon will help you. So whenever any patient comes to you with this is clinical. I mean, even if you are going into the round in your hospital, right, and you are seeing a post-op patients, right? So first of all, you need to see what time since surgery, post-op fever. So probably we divide 1 to 3 days, 3 to 7 days, right? 7 to 14 days, more than 14 days, blah, blah, right? So this is how you remember. First is a wind. So post-operatively, wind means lung. Wind, where is the wind or where is the air? So this is how it's acronymed in the book, wind. First is the wind. Second, just if you go below the lung, there is a bladder. So second is a water, wind, water. Below that, there is a leg, calf muscle. walking, right? Then wound, and then weird. So this is how the 5W is given in the book. If you open up any standard international book, you get these five things. So you start from up. Lung means wind, second water, walking, then operational wound and weird. These are the causes of post-operative fever, right? This is how you have to remember in that way, right? To just make little things more easier for you guys, right? So this is what the thing is. If I can show you what is the real things going on, so correct answer is UTI. Then sometime people think why it is UTI, sir, why it is not a wound infections? Because see, if you go to the scenario, 57-year-old woman underwent for cholecystectomy surgery. So surgery has been done, right, for 3 days back, right? So 3 days back. So you need to see beyond the 3 days what can happen. Fever is quite significant, 103, complaining of chills. Patient is not ambulating, right? So sometimes they, you feel that it could be a deep vein thrombosis, but they won't develop on day three, right? And great deal of pain at the incision. So somebody thinking, oh, great deal of pain at the incision, there must be some infection at the site of infection, I mean incision. So you thought this is a wound infection, right? So some people may thinking, those who did not posted answer. So you need to remember the time frame when the people gonna get the things, right? So this is the time frame. So what do you mean by fever or post of fever? So you must know the definition of fever. Not 100, it is 100.4 as per the book. The post of fever, definition of post of fever, temperature must be 38, more than 38, or 110.4 or 100.4 in post op period. Now in post op period, they divided in post op days. One, right? So first is wind. Wind means something related with the lung. In lung there is a atelectasis, means collapse of alveoli, right? So you need to know three things: what time frame, number one; what can cause, number two; and how you gonna treat this, as well, you must know, right? So if day two, 1 to 2 days, right, immediately post op, right, then wind or lung is at problem, so atelectasis, and another is a post op pneumonia, that is in the 1 day. So how you gonna prevent this? Atelectasis prevented by chest physiotherapy, chest PT or chest physiotherapy; pneumonia by prophylactic antibiotic. That is why we give the antibiotic pre-operatively to the patients for the prevention of the infections, right? So these two things you also must know in your mind, you must clear. So you start the chest physiotherapy very early, or if patient's lungs are weak, you can start even pre-operatively good chest physiotherapy, which makes the mucus to clear, which improves the ventilation, which open up the alveoli, and it reduces the risk of post-operative atelectasis and pneumonia. This is number one. UTI, right? So UTI is 3 to 5. Our patient is in this frame, 3 to 5. And that is why the answer is UTI. UTI means urinary tract infection. Wind and water. Where is the water in the body? It's in the urinary tract, right? Bladder, kidney, ureter, blah, blah. So urinary tract infection. So first we have seen wind, that is in the lung, then water, that is in UTI. So how you gonna treat this? How you, what you need to know the treatment as well, not just the cause. So how you, so you early ambulize the patient. Early ambulation, that is always goal for any surgery, right? Head to toe any surgery, this is goal, right? Number one, early embolization, removal of the catheter, early removal of the catheter, just to reduce the catheter induced urinary tract infection or infection, right? So, and hydration. So these are the things by which, and obviously prophylactic antibiotic in all cases will going to prevent the infection. So this is what the basic rule. After 5 to 7 days, right, causes is walking. So wind, then water, and then walking. So if you don't walk patients, if you don't ambulate the patient, they develop the deep vein thrombosis. How you gonna prevent it? Early ambulation is the goal in, right? Hydration is important, and prophylactic low molecular weight heparin we are giving in many patients, especially in a lower limb surgery or knee replacement or pelvic or hip surgery, right? So this is what the thing is. So eventually DVT can cause pulmonary embolism, so low molecular will take care of DVT as well as PE or pulmonary embolism. That's all. So this is 7 days. So wind, water, walking is done. Now after 7 days of wound in operation, infection, the wound of the operation, that is a cause. So wound infection, wound can cause. So regular dressing of the wound is very important from the day one after post-operative surgery. If you don't take care of the wound, eventually in 5 to 7 days, the bacteria will grow at the site of the incision and then eventually develop. But this take at least 7 days to develop in general in any patient. So this is the time frame, and beyond 1 week, right? Or second week, you can say probably weird. Weird means something unusual. One is drug fever. So if somebody's developed drug fever, and second is a deep-seated abscess. So like somebody did the liver surgery or gallbladder surgery, presenting after 2 weeks with the fever. Probably at the site of cholecystectomy, he may develop liver abscess or local abscess. So abscess usually take 1 to 2 week of time. It won't develop in 1 or 2 day abscess. Wound never gets infected in 1 or 2 day. It takes at least 1 week. So you need to remember wound, water, walking, wound, wind, water, walking, wound, and last but not the least, weird, which includes two things mainly: some drugs sometimes you are missing, which may cause, and abscess. That's it. So this is how you have to remember, right? We don't need to mug up the things. We don't need to mug up the things. We need to understand the things how we gonna suppose tackle the post of fever or post of this complication. Is that clear to everyone? At least tell me yes or no. Is that clear to
Yes,
everyone?
sir. It is clear.
Wonderful. So just don't get panic in the exam. Probably I'd given you the 3 day time. They may probably give you 5 days. They may give you 7 days. They give after 2 weeks. Patient develop fever. So you just remember the basic. If you remember the basic, right? Our scenario is like post op 3 days, right? But it is not mandatory. They always ask post op 3 days. They may ask post op 7 days, right? So you need to remember this. Cause this is what things 5W and treatment. I also explain you the treatment as well. So three things you need to know at the what post-op time patient present, what could be the tentative cause, and what could be the treatment of this cause. Is that clear to everyone? Yes or no? Tell me yes or no.
Yes, sir. It is clear.
Wonderful. So don't miss this. It is absolutely high, very, very high yield, I can say, in the hospital, right? When you are working in a hospital or clinic or multi-speciality, wherever, post-op fever is the biggest headache, right? Where you are, I mean, sending lots of blood culture, CRPs, urine culture, stool culture, chest X-ray. But if you know this, then you probably save the time and money of the patients as well, right? So let's move to the next question. So this is all done. So this is post-op fever. Everyone must know it, right? So this is the most common cause. This all as per the day. Little long scenario, but not difficult. Keep your concentrate here. All are absolute high yield exam oriented question. 70-year-old man with diabetes, hyperlipidemia, and tobacco abuse present to the emergency department with chest pain for past 3 days. The pain is worse with the exertion and was relieved by sublingual nitroglycerin until today. When the pain persisted, it radiates to the jaw and associated with nausea and diaphoresis. On examination, the blood pressure is 90 over 50 millimeter of Hg with the heart rate of 95 beats per minute. He has a 2/C hollow systolic murmur at the right lower sternal border, and the JVD is 12 millimeter of H2O, or you can say JVD pressure is 12 millimeter. The electrocardiogram reveals ST segment depression in the inferior leads. CK ambient troponins both are elevated, and the patient is diagnosed with non-STEMI segment elevation of myocardial infarction. Which of the following medication should be avoided in the management of this patient? Heparin, aspirin, nitroglycerin, ACE inhibitor, or something else? No need to get panic. Take your own time. Post your answer in the chat box. We will completely discuss acute coronary syndrome in one question. So we're gonna do 10 questions minimum. First of all, you need to know what is the diagnosis, what point favors the diagnosis or investigation, what is the treatment of this patient, and they are asking treatment, but what you can avoid it in this patient. So take your time, think over it these questions, and then post your answer in 5 10 seconds. Yeah. Somebody joined with the iPhone A. Anybody iPhone posted the answer? I don't know the name. Yes, post your answer. Post your answer. Yeah, so let's Dr. Santosh Paudel, tell me what is the diagnosis? I've seen your answer is a C. So let's little discuss why you think this is C, what's the diagnosis, what's really going on. If you are not busy somewhere, you can interact.
Yes, sir. Good morning, sir.
Very good morning, sir. Yes, so
Uh,
now, first of all, tell me what is the diagnosis?
it's mentioned in inferior wall MI, ST segment
Okay,
diffusion, non-STEMI
okay.
MI,
So first of all, acute MI, right?
acute MI, yes, sir.
Then decide which wall, anterior, lateral,
Inferior walls,
anterolateral, or inferior. Huh?
inferior wall, sir.
Inferior wall. Now one question, inferior wall. Why? Because they have mentioned
Inferior
the
leads,
ST elevation in inferior lead, so probably
leads,
it's a inferior wall.
wall, 2-3 AVF.
Fair enough. 2-3 AVF. Wonderful. Lead 2, lead 3 AVF. Augmented. All right. Fair enough. Now, what point favors the acute MI in this scenario? What do you think? What this point favors in MI? What happens to
The
enzyme?
the enzymes are elevated and
Okay, enzymes are elevated. So there are two enzymes, troponin I or T and CKMB. These are the
CKMB.
two main specific cardiac enzyme, right?
Yes, yes,
So
sir.
what do you think when the troponin T or I will get elevated? So three questions here. When it will start to increase in plasma, when it will
Uh,
become a peak, and how long they stay in the plasma. These three questions for this. There are hundreds of questions on acute coronary. So we're trying to solve all the very quickly. So troponin I at what time? Say
in
12
4 to
o'clock, patient develop acute MI
4
in the
to 6
afternoon.
hours.
Right. So first answer is 4 to 6 hours. So within
So
4 to 6 hours of chest pain or acute MI, this enzyme gets elevated. I mean, start raising in the plasma. At
yes, sir.
so this is the normal. Now drop after 4 to 6 hours. This is 0 hours. 4 to 6 hours, this start getting elevated in the plasma. At
Yes, sir.
what level or what time it will become a peak maximum?
2 days.
Sorry,
I don't know. 2 days, sir. Probably
no 2 days,
1 to
12
2
hours.
weeks.
Just for your
one
knowledge.
two
No, no,
weeks.
no.
12
Remember,
hours.
yeah. What is my question? At what time they become peak? Peak means
Peak.
maximum. Here the level is
Uh,
10, then 15, then 20, then 30. So at 12 hours, they are on peak. Here they started
um,
from 0 to 1, 2, 3, 4, 5, 7. Peak at 12 hours, right? They remains in the plasma. They remains in the plasma for 1 to 2.
2 days. Weeks.
Weeks.
Excellent.
Mm.
2 weeks, right? So this is extremely important. This is one question, right? Where there is a three question. Second questions, right? When you want to know infarction and when you want to know reinfarction. How did you get to know that this is a reinfarction, right? So this is the same three questions here. Again, this is 4 to 6 hours. They got elevated, they remains peak, right? From 12 to 14 hours, same. But here the
1
only
to 2 days.
change,
1
major
to 2
change,
days.
instead of 1 to 2 weeks,
2 days.
they remain 1 to 2 days,
Days.
2 days.
right? So don't remember in days because it will confusing. Six, some books say 6 to 10 days, some 8 to 10 days, 14 days. So this is I invented my own things. 1 to 2, both the things 1 to 2, but this is week, this is day. That's it. So this is simple to remember, isn't it? Yes or no?
Yes.
Right? So say for example, patient develops today infarction, right? Means up to 14 days, maximum 14 days, trop I will be elevated. Trop I will be elevated. And the same thing, today somebody developed the MI and CKMB elevated just for the 2 days maximum CKMB. So again, it becomes normal. And on day 3, day 4, day 5, up to 14 days, if you get again elevated CKMB, that means there is a recurrent MI. You
Really.
should get. So
Yes.
for 12 hours per, after 48 hours normal, uh, 3, 4, 5 days normal, again CKMB going rise means it is a re-MI, reinfarction, re-MI. While up to 14 days, right? Up to 14 days, the troponin will get elevated up to 14 days, right? So after 14 days, if something is happens, then again you need to know, right? Reinfarction is because of right, reinfarction is there or not, then again both will get elevated, right? After 1 month, if somebody develop chest pain, right, then CKMB and trop I will get elevated again after normal. So what is the pattern? Right, trop I after 14 days they normal, after 14 days they normal, they are after 2 days they are normal, but something goes wrong after 14 days, again it will get elevated. CKMB after 2 days something goes wrong, again it elevated. You understand? Yes or no? At least tell me yes or no. If you don't know, just ask me the question. But it is absolutely high yield, right? So reinfarctions can be right. So base test in the initial phase for reinfarction is CKMB, reinfarction initial, right? So, and most of the patient with acute myocardial infarction, they discharge within 1 week to 2 weeks max, right? So say for example, patient came with a chest pain, right? Three things you need to see: symptoms, chest pain, third, second is ECG, and third is enzyme. So symptoms are classical: chest pain, radiation, jaw pain, wrist pain, ST segment is elevated, 2-3 AVF elevated, that is inferior MI, and drop I and CKMB both elevated. That's it. This is how you make a diagnosis for all acute MI in general, right? But these enzymes behave in a different way, so you need to know the logistic of the enzymes when they get elevated, peak, and then down normal, get elevated, peak, down normal, right? So that's it. So this is a classical case of acute inferior or
Well,
STEMI. Now you somebody told heparin. So why the heparin is answered? Why you want to avoid the heparin in this patient? Why you want to I mean avoid the heparin in this patient? There are few answers which mention that heparin should be avoided. So I want to just know, somebody has given the answer a heparin is avoided. So why you want to avoid the heparin, right? Or aspirin or nitrates, or so most of the people give the answer nitrate should be avoided. So again I get back to you, Dr. Santosh. Why you
yes.
want to avoid the nitrates in this patient? There must
Uh,
be some reason for avoiding or not adding the nitrate in this patient. Now tell me.
Usually nitrates they decrease the preload, so already the BP is in the lower side 90 by 50, so they will cause hypotension, sir.
Excellent, wonderful. So there are, so we diagnose the MI. How did we diagnose? One is a clinical history, right? Or history first, then ECG, and enzyme.
Enzymes.
Never ever you never ever order the enzyme before ECG.
Yes, sir.
This is the word I written in my book. Chest pain is equal to ECG. That's it.
ECG.
Any patient 10 years, 20 years, 30 years, 40 years, 50 years, 100 years, come with chest pain, do the ECG. If it is normal in 20 years of age, that is fine. Okay, fine. 20 years of young man, you what you think? Oh, 20 years of never happened. Am I in 20 years of age? I have seen who develop at 15 years of age. What to do? How you defend? Nothing. So ECG, by my experience, is a underutilized investigation. I don't know, we are afraid of doing the ECG. I have seen many doctors. They never ask for ECG. They thought, oh, 18 years of boy young, oh, it's not ECG. It could be probably GERD. But out of 100, probably two have they have bad MI and they die. Do you afford to die somebody 18 years of age die because of acute MI and you missed it? Are you happy? Yes or no?
No, sir.
Never ever, right? So any patients take a today oath. Any patient comes to your OPD, IPD, emergency, non-emergency, whenever they are, I mean, don't ignore it. The complaint, chest pain is an emergency. Chest pain is emergency until proved otherwise. Do simple ECG, 20, 30 years of age. If it is normal, okay, fine. This is not a cardiac. That's it. You rule out the cardiac because this is the leading cause of death globally. Leading cause of death globally is a cardiac death, either acute MI or VTVF or cardiac failure or whatever. I mean, cardiac, any problem in endocardium, myocardium, or pericardium, people will die, right? So don't ignore it. ECG is absolutely basic, available everywhere across the globe. Smallest of the smallest hospital has ECG, right, in any part of the world. So don't underutilize it, fully overutilize it. Chest pain, do ECG. Khalas, right? If it is normal, fine. Nobody will blame you why you did a ECG. But if somebody die at 20 years of age with chest pain, everybody will come and scold you. And probably, I don't know, in foreign countries, probably a problem with the license as well. Chest pain, no ECG, it's a crime. I don't know. Because I did work in Middle East country, right? In Oman, initial I started my career. So I did ECG, right? And when somebody died and you did not did, then 100 people will come from ministry, right? And then ask you, oh, why you did not did doctor ECG? Why, blah, blah. Then hundreds of things, and it's a headache. So don't underestimate, underutilize it, overutilize it. By my sense, that's it. So this is number one. So now you diagnose somebody with the acute MI. Three questions. What is the initial treatment? What is
Mona.
the most initial or most effective or next best management? This is how the question comes. So now this patient comes to you, Dr. Santosh.
Yes.
Acute inferior wall MI. What would you want to do? Because you took a history examination, you did it ECG, inferior wall 2-3 AVM, you did enzyme, everything is now confirmed, right? That this patient has acute inferior wall MI. Now, what's your treatment plan? What will you give
First,
to this patient?
if there is
Same patient. If
availability
I
of
ask
the
you the treatment, treat this patient, then what is the treatment?
PCI, sir,
Sorry,
percutaneous intervention.
percutaneous, percutaneous intervention or primary coronary intervention or percutaneous coronary intervention. So the answer here is a wrong initially because you cannot ignore the initial treatment in acute MI. Number one, if any MI XYZ any MI, how any
Basic.
MI there are dictum S1, S2.
Just
I mean
to
S, I mean lead one, lead two, lead three, lead four, lead five, lead six. That is what I called as a SALI. A L and I, Sali. Sali, sister of wife is Sali in Hindi, right? So lead V1 and V2 is septal.
septal.
A means
V3,
anterior,
V3,
V3,
viva.
V4. L for lateral, V5, V6.
B6.
And inferior is 2,
2, 3,
3
3
AVF.
AVF.
This is how I remember. Probably it's easy. So this is the heart, right? This is heart, this is intraventricular septum. So first lead on the right side, V1, V2, V3, V4, V5, V6 for your understanding. So V1, V2 is at the site of the septum, intraventricular septum. So it is S. This is at the anterior wall. That is why A. This is on the most extreme lateral L. And below that is inferior is I. Sali. S1, V1, V2 is a septal. V3, V4 is a anterior. L means lateral, V5, V6 and inferior 2, 3 AVF. This is what simplest form I can teach you. Is that clear to everyone? Yes or no? No need to mug up. Yes or no? At least tell me yes or no. Right?
Yes.
So this is
Yes,
SALI.
sir.
So
Yes, sir.
remember acronym. Remember the acronym SALI. SALI is a septal anterior. Two you need to add two tooling. 1, 2, 3, 4, 5, 6. SAL and inferior. That's it. 2, 3 AVF is inferior. So now this is acute inferior wall MI. So it means somewhere here the heart muscles are dying because of lack of blood supply or coronary. Which Dr. Santosh, which coronary artery will supply to the inferior wall? Which artery will supply to the inferior wall? It's also important.
Left ascending.
Right coronary
Right
artery.
coronary artery.
Uh,
Excellent,
right.
excellent. So
Right.
70% of the heart or 70 to 75 by the left coronary artery. So left coronary artery, right? Let me draw the left coronary, these things, little change in the color. So left coronary here, right? 70% of the heart is supplied by the left coronary artery.
Coronary artery.
And third, so inferior and posterior wall, is supplied by the right coronary artery, right? Right coronary RCA. So when there is a problem in the RCA, right coronary artery, you get the posterior wall MI or inferior wall MI. So you don't need to mug up. You need to understand left side of heart, left coronary, right side of heart, right coronary artery. Right. So right coronary artery supplies right side of heart, inferior and posterior. Left, right. So this is left. Which another question? Which is a more fatal? Left coronary blockage is more fatal. Right coronary artery blockage is more fatal. If the left coronary
Left.
100%
Left coronary artery.
block and right coronary is 100% block, which is more fatal? Left coronary
Left
artery.
coronary artery.
Left
Left
colon.
coronary artery. So always remember, these all are the questions in exam, right? Prognostic, which is prognostically bad, you need to know. And how did you get to know? By angiography, coronary angiography. But before doing the coronary angiography, let's back to this question. You got a patient with the acute inferior wall MI, which is diagnosed by history, physical examination, ECG enzyme. Now, final diagnosis is acute MI. Now, you want to treat this patient. So, what is the patient if in your emergency with acute inferior wall MI diagnosed case now? What is your first drug? What you give the
First is
first drug to this patient?
Aspirin.
Acute
aspirin.
inferior wall
At
MI. So remember, my dear brother and sister, never ever
Mona.
miss Mona. Never ever miss Mona. Any part in the world, including US, nobody is going to go beyond the Mona. So this is the initial treatment. Initial treatment is Mona, and most of the acute MI, for your kind knowledge, at develop at home, not develop within hospital. So patient is not going into the hospital, right? By knowing, oh, I may probably develop MI, I'll reach to hospital. Never ever. They started the chest pain at home and then they reach to hospital. Probably hospital is 10 minutes away, probably 1 hour away, probably 3 hours away, right? Depends. You never know what is the nearest medical center for them, right? So MONA is a forward. M stands for morphine,
Morphine.
morphine, right? O stands for oxygen,
Oxygen.
right? N stands for nitrate or
It's
nitroglycerin, and A stands for aspirin. Now we'll discuss a lot of things. All questions, acute MI will cover today. So MONA is, you cannot miss the MONA in any MI. Any MI means Sali wala MI. Whether it is a septal, give MONA, anterior, give MONA, lateral. If you have V1 to V6, all V1 to C6, all this involved, then it is called as a global or massive MI. Global, all complete, all antio septal or anterior, right? Septal, anterior, and lateral wall, very biggest MI. All leads are involved, means all this coronary is very badly blocked, right? So in that case, right? So whatever the, whether septal you give MONA, anterior, lateral, inferior, anywhere you give the MONA, number one. Now we see the indication and contraindication. Indication, contraindication. Which drugs? So second, number one question. Let me start question. This all question in DHA are there, Mocha. I'm discussing that only, right? Which drug? Question. Options are same for all questions. Options are same. MONA, four drug, morphine, oxygen, nitrate. Which drug, right, improves the overall survival? Which drugs improve the survival in the patient? Morphine improves survival, oxygen improves survival, nitrate improves survival, aspirin improves survival.
Aspirin.
aspirin.
Nitrate.
Aspirin, sir. Aspirin.
Excellent, wonderful. Aspirin. So here the question's answer is aspirin, right? So out of MONA, MON and A, this is not improve the survival, this is not improve survival, this is not improve survival. Aspirin improve survival. What does it mean? It's a practical implication. We don't need to mug up. Whenever any acute MI patient comes, I will give first aspirin, then oxygen to that patient. Believe me, I'll give aspirin, then morphine. I will not give nitrate before aspirin. Means aspirin is the priority. That does not mean you will not give the nitrates to relieve the chest pain. You must give, but the priority, the most important priority is aspirin. You never ever miss the aspirin. Number one. Is that clear to everyone? Yes or no? At
Yes,
least
sir.
tell me yes
Yes,
or no.
yes, sir.
Yes, sir. Yes, sir.
Wonderful. Second thing, second question, same, continuing with this. What is the absolute contraindication of aspirin. Absolute contraindication of aspirin.
GI
Second
bleed.
question. Third question.
Hypersensitivity.
1 second.
GI
Yes.
bleed.
So GI bleed. What do you mean by GI bleed? Explain me GI bleed. If patient has ongoing GI bleed and develop acute MI, in that case you won't give. Or 2 years back he has a GI bleed and now patient present with the acute MI, then you won't give. Little define what you understand by GI bleed. If I can say this patient has a past history of GI bleed 3 years ago and now patient develop acute MI, are you going to give aspirin? Yes or no? If yes, why yes? If no, why no? Yes, tell me. Go ahead. We don't need to mug up. That is why we are going in practical things. You are right, GI. But what do you mean by GI bleed? Whether GI bleed 5 years back, GI bleed 6 months back, GI bleed today, or GI bleed yesterday, then you don't want to give anyone open for all.
Active ongoing.
Ongoing only.
Ongoing means
Ongoing
the
and
patient.
recent history of
No, I mean, how many, honestly speaking, we are more than 20, 30 doctors now in group. So honestly speaking, I never seen any patient who has developed acute MI and he has GI bleed. We have not started any treatment. Patient came to emergency, history ECG enzymes showing acute MI. Now we are going to give Mona, right? But before that, I need to make sure that in which patients I cannot give the aspirin. So how do I get to know that this patient has a GI bleed now? First of all, how did you get to know?
antiplatelet drug is taken.
Patient is not taking any antiplatelet. This is the first time patient developed the things. There is no past history of GI bleed. Patient does not have. Patient does not have GERD. Patient does not have gastric or duodenal ulcer. What do you mean by GI ulcer or GI bleed is contraindicated? So go and read it, right? You also do some exercise the way I committedly do. You also do little exercise and tell me. It's all important because in clinic when you are in the emergency room and if you are not giving this drug to the patient, you are doing crime. Believe me. So there is a contraindication, but you need to know what do you mean exactly by GI bleed. Number one, what is the second or even more important contraindication? One is GI bleed, but I want to know.
Hypersensitivity.
Excellent. Hypersensitivity. Hypersensitivity. What do you mean by hypersensitivity, doctor? What do you mean by hypersensitivity? Can you define hypersensitivity of aspirin? If the patient has a 6 month back, this patient develop some itching after aspirin. Do you consider it as a hypersensitivity or patient develop anaphylaxis and shock after taking hypersensitivity? Then and then you consider that it's a hypersensitivity. So what is the exactly understanding in your mind about the hypersensitivity to aspirin? What exactly the side effect develop after taking aspirin and you called it as a hypersensitivity? Are you getting my question? Yes or no? Yes or no?
Yes, sir.
Wonderful. So you define because this is the life-saving drug. If you are not giving this drug to the patient, right, in indicated patients because of some misconception in your mind, patient will die. Believe me. I'll come to the statistic, official, as per the book. Yes. Anyone wants to comment on this? How you define
Even
the
itching,
hypersensitive?
even itching we considered as allergy. Itching or any swelling, shortness of breath, and anaphylaxis following aspirin.
That is absolutely yes. Why? Because aspirin and anaphylaxis means you cannot re-challenge. But I want to know what is exactly hypersensitivity of aspirin. Second homework. Second homework. First homework. I would be glad and happy the way I am giving my 100% to make this lecture interesting. This is for you only. I'm not going to appear for exam. Let me tell you, I'm a mentor, right? So you need to know what is a GI bleed, exactly what you understand by GI bleed, what time frame, before how many months GI bleed or days or weeks, or in which cases of GI bleed you cannot give it. Go and read it. Second, hypersensitivity. Go and read it. Third, anything else? Yes. So these are the two contraindication, but I want to know exactly what is in your mind. That is why I'm giving you little homework. Sorry for that, but it's required, needed. Fair enough. Go ahead. Any other third
Sir, in the asthma
contraindication?
patient,
Asthma patient we can
sometimes
give.
tired,
Mild patient,
nasal
mild patient. Fine, fair enough. This asthma patient, you can say. But if asthma patient does not have Asthma patient does not have, I mean, breathlessness or any cardiac or any other respiratory issue in emergency, and now he has acute MI. You are not going to give. Patient is stable from asthma side. Patient has well settled asthma. Patient has no breathlessness, is well controlled for many years. Now come with the acute infeval MI. Are you not going to give the aspirin? Go and read it. So my thing is absolutely so. In nutshell, go and read the contraindication of aspirin. That's it. This is the broad term homework. Contraindication of aspirin. Indication everybody knows now. We need to know the contraindication. Second questions, right? So this is solved, right? Aspirin, we know aspirin has an overall survival advantage. It is an excellent drug. Indication we know. Second question is what are the contraindication for aspirin? Third question in exam, if the aspirin is contraindicated, then what is the next drug of choice? So say for example, patient has clear cut anaphylaxis of this, you knows, everybody knows, doctor knows. Now you will not give any antiplatelet to this acute infeval MI patient, or you want to give, or you can avoid. So you just give MON. You don't give the aspirin. Anyone?
Clopidogrel like drugs.
I'm not getting your voice. Sorry.
Clopidogrel.
Clopidogrel. Excellent. So remember, everyone answer. The answer is the clopidogrel. So aspirin is antiplatelet. Clopidogrel is also antiplatelet. So you must give the clopidogrel to this patient. Is that clear? So now
Yes.
we are done with the aspirin. What is the role of morphine? Why you want to give the morphine? Anyone can answer.
Small
Coronary
pain.
artery dilation,
Sorry.
dilation of the coronary arteries for the better blood supply to the heart.
So nitrate is also you are giving, na? Then tell me what is the functions of nitrate? How the nitrates will help in
Sorry,
acute MI
so
in this
first
patient?
about the nitrate, morphine is more for the pain relief because the patient is in acute chest pain.
Yeah.
So morphine is for the pain relief so that we can take the history from the patient.
Fair enough. One more questions. You are giving the morphine for the chest pain relief, right? That is what you answered me. Am I right? Yes or no?
Yes, sir.
Right. So if I can tell you, I need to give contramol. I don't want to give. Why every guideline says morphine only? Contramol is a also again a good drug. Tramadol, you can say tramadol. Why you don't want to give diclofenac? That is also a good painkiller. Why you want to stick to only morphine? Is there any specific things in morphine? Why you don't want to give any? Because there is a long, na? If you go through the pain ladder, you can start with the paracetamol, ibuprofen, diclofenac, then tramadol plus paracetamol, codeine, then you can give fentanyl and then morphine and this fentanyl patch, and there are thousands of things in pain ladder. If you don't know pain ladder, go and read it, because pain is something which every individual on the planet experience once in lifetime minimum, whether it is
Reduce
so.
anxiety.
Then you give Alprax. Why you want to give
Causes
morphine?
Vasodilation of the blood vessel, so it decreases the workload of the heart, sir.
venodilation is also a characteristic of morphine, sir. It decreases the preload.
Okay, so that is why we are giving morphine. So morphine is given to reduce the chest pain, right?
It reduces the chest pain and decrease the preload.
Okay. Any other comment? Because we are always many years and years we are reading morphine, but we don't know why we are giving morphine.
It reduces the heart's workload and increases the oxygen supply.
Okay. So first of all, you given the answer well. I'm not saying no, but the real genuine reason, three benefit of giving morphine in myocardial infarction. One is a pain relief. Why morphine only? Because it is one of the most and strongest potent analgesic, right? Then other contramol, diclofenac, ibuprofen. This is one of the most central acting morphine pain killing. So pain killing effect is the most. When there is a severe, you know the pain score, yes or no? Yes or no? Pain score. Anybody knows the pain score? Yes or no?
No, sir.
Come on. Pain score is a pain is fifth vitals by my sense. Temperature, pulse, BP, oxygen, and pain is a fifth vitals. So pain is a you need to ask the pain score. Anyone knows pain score?
0 to 10.
Yes, so 0 to 10 is a pain score, but how you define the 0 to 10 this pain score?
Zero means
So
0 minimal, 5 more.
zero means no pain, sir. And then divided into three each. 1 to 3 is mild pain, 4 to 6 is moderate, and then 7 to 10 will be severe.
fair enough. So that is the pain score. So those who don't know absolutely what is a pain score, I strongly recommend go and read the pain score. It is absolutely given in all books, internationally, nationally, everywhere. This is very basic, right? So pain score. So there is a chart, right, which measures 0 to 10, right? So you tell the patient what is the pain score. Tell him what is the number of your pain, 0 to 10. Got it? So 0 is no pain, 10 is worst pain in the lifetime, worst pain, right? So if somebody, 8, 9, 10 is the worst pain, 8, 9, 10. So 0, 1, 2, 3, mild. You can say in simple language, mild. 4 to 7 is moderate. 8 to 10 is a severe pain. So acute MI, renal colic, this pain are 8, 9, 10 pain. When you ask the patient when they are really passing from pain. Any patient comes with a bad renal colic or ureteric stone, comes in the emergency and you show the chart, what is the pain score? He will tell you 10 out of 10. He will tell you worst pain he ever experienced in his or her lifetime, right? So in that case, the morphine is the strongest painkiller, strongest, and that is why it is used. Paracetamol is not strong, it's a mild. So when patient has a 10 pain score, when you have a severe pain and you are giving paracetamol, doesn't work. When you're giving tramadol, doesn't work. You need something which relieves the pain. Is that clear? Yes or no?
Yes,
Yes
sir.
or no? So pain relief, number one, somebody told anxiety reduction. That is also another effect or side effect, right? But anxiety is also relieved. And the biggest thing is that this reduce the myocardial oxygen demand. Reduce the myocardial oxygen demand. So morphine can lower the sympathetic activity, preload and afterload, and potentially reducing the heart's oxygen demand. Because when there is a ischemia, they needs more oxygen supply to the heart to make this tissue live or to active. Otherwise, heart muscle will die because of lack of blood supply. Right or left coronary is gone. It's blocked 90%, 80%, 100%. So oxygen, nutrient, and blood is not supplying to that part of the muscle, right? So it reduces the oxygen demand. So you are giving chance of the heart to become more few minutes more live, right? So this is the advantage of morphine. So morphine three advantage: strongest painkiller, anxiety, reduced oxygen demand. Is that clear? Yes or no? At least tell me yes or no.
Yes, sir.
Yes, sir.
Comes to the oxygen. So morphine is done oxygen. What is your thought process on the oxygen? If I can tell you acute myocardial infarction, acute MI, inferior wall MI, right? Same patient, and on admission, patient has a 95% oxygen saturation as room air. Are you going to give it or not? Some patient has a 92%. Are you going to give it or not? Somebody has a 90% room air oxygen. Are you going to give or not? Give your thought process.
Normally 94%, sir. Less than 94%, we would prefer to give oxygen. Greater than 94 at room temperature, oxygen until and unless necessary, we won't give.
Fair enough. If you give in this patient, what harms can happen? Or there is no harm. If my patient has a 95% room air temperature and senior is saying, sir, give start Mona, O means oxygen. So what you will do? You give or you don't give? Patient has clear cut, stable 95, even sometime it going up to 96 as well. So let me tell you, hypoxia, less oxygen means less than anything less than 92%. You must give. No discussion, you must give. 92 to 95, if you give, there is no harm. No harm. Even more than 95%, literature is showing, book is showing there is no harm, right? Because there is a some kind of increased oxygen demand to the heart or the muscle of the heart. So if you give, there is no harm. Even if you don't give at more than 95, there is no harm. Even if you give at more than 95, even though there is a no harm. So no need to get confused yourself. Depends on your practice in your hospital or your legal laws, you can do it, right? But absolutely, when hypoxia, you must give it. Is that clear? Yes or no? So morphine, oxygen, aspirin is done. Now nitrate. Three questions in nitrate. How the nitrate will help in acute myocardial infarction? How it can help? What is the indication of nitrate? What is contraindication of nitrate? You never thought of some such kind of questions in the exam. That is why I'm discussing. We just mug up Mona, Khalas, Mona, but what Mona? I mean, why you use Mona? What is the indication, contraindication of Mona? Probably you are listening this logic first time. I don't know.
Sir, nitrates cause coronary dilation, so they will increase the coronary blood flow.
Okay,
And
so
they,
dilatation, it will do the coronary vasodilatation. So
yes,
arterial dilatation, coronary artery, or venous dilatation, or what dilatation? If I can tell.
all the three, sir. They even do venodilation, which will decrease the preload, and they do the arterial dilation, which will decrease the afterload, and coronary dilation will help them to increase the heart blood flow, coronary blood flow.
Fine. So coronary blood flow improves. That means pain is also reduced, right?
Yes, sir.
Yes, sir.
Pain is also reduced because main culprit is what? Because of blockage, heart muscle is not getting the oxygen and blood. So now you are doing something which improves the blood flow to the heart. Yes or no?
Yes, sir.
So
Yes.
your pain is also reducing. If patient is hypertensive, blood pressure is also get little controlled. Isn't it? Yes or no? Right?
Yes, sir.
So heart is getting better blood flow, blood pressure is also getting better, pain is also getting better, and that is the reason why you are giving sublingual nitroglycerin or NTG, right? Immediately. So it start the vasodilation as fast as possible. So patient is at least chest pain relieved. And when chest pain is relieved, he will give you some history. Nobody will give you history in a 10 out of 10 chest pain. Even I cannot give. Nobody can give. He is in the pain. He don't want to listen anything. He's in the tremendous pain. He wants to reduce the pain. So do something which reduces the pain in acute MI immediately. So that is the morphine and nitrate. Oxygen will not reduce pain. Aspirin will not reduce the pain, right? Morphine and nitrate will reduce the pain. So if you want to take proper cool and calm, make the patient give morphine, give nitrate. I mean, obviously, aspirin you give it, but this too will reduce the pain. Is that clear? Yes or no?
Yes, sir.
Come to the contraindication. In which condition you cannot give the nitrates?
Hypotension.
Cardiogenic
Hypotension.
shock. Yes, sir.
So shortly, any systolic blood pressure less than 90 because of any shock, five shock,
Hmm.
division, hypovolemic shock, right? It includes the hemorrhagic shock or dehydration. So hypovolemic shock,
Hmm.
septic shock, cardiac shock, anaphylactic shock, and neurogenic shock. If you forget the shock, go and read it. These are the five shocks, right, in the chapter and in the book. So I told all five. So irrespective of shock, just simple one line word, any systolic less than 90, nitrate is contraindicated. That's it. Is that clear?
Yes, sir.
What is the another contraindication? Have you heard of this drug?
Sildenafil.
Have you heard of this drug sildenafil? Yes
Yeah.
or no?
Yes, sir.
Yes, sir.
Globally very famous brand as a Viagra that
Hmm.
is used mainly for the patients of impotence or sexual disturbance or erectile dysfunction, the Viagra. So there are lots of people in across the globe this drug is taking. So you need to know before giving the nitrate whether patient is on sildenafil or Viagra? If yes, you cannot use it. You need to tell me reason why. Because sildenafil reduces the blood pressure, right? And nitrate also reduces the blood pressure. So if you club up both the sildenafil plus nitroglycerin, it will produce both the drug profound hypotension or low blood pressure. Better you avoid. Is that clear? Yes or no?
Yes, sir.
Excellent. So that's all for the Mona. That's all for the Mona. So any questions you get ready now, don't tell me, sir, I did not know why this is given. So let's get back to again the acute MI. So acute inferior wall MI, history, examination, ECG, enzyme, everything confirms things. First initial treatment is Mona. Is that clear, everyone? Yes or no?
Yes,
Yes,
sir.
sir.
Yes, sir.
Once you had given the Mona, what is the best treatment? If your hospital is one of the best hospital in the world, what you want to do? Your hospital is the best hospital in the world. Everything you have it. Now what you want to do?
Percutaneous
PCI.
intervention,
Coronary intervention.
PCI, depending on the timing.
PCM.
Fair enough. So patient present. So again, you raise the question, what is the time frame of PCI? Patient
90
came to you 12 o'clock, 10 o'clock in the morning, 10 a.m. patient came to you, right? You diagnose at 10:10. You within 5-10 minutes you diagnose it is acute inferior wall MI. You already given Mona is not. I mean, nitrate aspirin is not contraindicated. No allergy, no anaphylaxis, nothing. No hypertension, nothing. Right? Pain is there, so you had given Mona. Now, up to what time you can do the PCI? At what time?
11:30.
Within
11:30.
2
hours.
hours.
90 minutes.
90
So
minutes
one,
from the
one.
admission.
So one is a 90-minute answer. Any answer?
120 minutes, sir, 2 hours.
Somebody is saying 120 minute. Okay, fine. Any other answer? Any other answer? Have you heard the two terminology? Door to balloon, and another word is door to needle. Have you heard of this word while you are reading the books or master the board or any other Harrison? Yes or no? At
Door,
least tell me yes or
Yes,
Yes,
no.
sir.
sir.
door to balloon time is less than 90 minutes.
90 minutes.
Okay,
More
so
than 120 minutes.
The middle is 2 hours.
fair enough, fair enough.
120
So
minutes.
fine. So overall, by my knowledge, though I'm not a cardiologist, I'm hematologist, but I deliver thousands of lectures. So probably my knowledge is 90 minute. Door to needle means what? When patient comes to your emergency door, and if you can do it right, door to balloon is a right balloon angioplasty or coronary angioplasty or graphy. Another word is PCI. So if you can able to manage within 90 minutes of acute MI, you better go for this. You better go for this. Say for example, so this is the first best treatment across the globe, right? But it is not mandatory. Every hospital has PCI. They don't have cath lab. They don't have cardiac unit. They don't have facility of coronary angiography or angioplasty. In that case, second best option is the thrombolytic. Is that clear? Yes or no?
Yes, sir.
The word is door to needle means the door of your emergency door, right? To needle means within 60 minutes. If you can able to give streptokinase, urokinase, altiplase, or TPA, with this all are the thrombolytic, which burst the clot. Two word thrombo means thrombus, lytics means breakdown. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Why thrombolytic? Because this is normal coronary artery, and here there is a 90% block because of clot. So you want to burst this. So this is thrombus. You want to break the thrombus, give the thrombolytic. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Yes.
This time frame you must keep in mind while doing this, right? You go and check it. If it is 120 minute, you post it in the group from the official book. But what so far I know in my knowledge is 90 minute, right? But probably you can cross check it. If it is 120, I would be happy to improve my knowledge, no worries, right? But so far it is 90 and 60, right? So this is what the thing is. So there are 100 questions of acute myocardial infarction in a different way. I tried my level best to catch major questions. Still I can speak on 1 more hour on acute mi, but this is exam point of view. we
Sir,
we
this
go ahead.
thrombolytics is only 60 minutes, sir.
Thrombolytic means oh sorry,
Uh,
thrombolytic you can go up to thrombolytic, I mean door to needle time, not
yes, yes.
thrombolytic. Door to needle ideal time. Door to needle ideal time is 60 minutes and door to balloon is 120 minutes. But if you don't have the facility, up to 12 hours you can do it.
Thrombolytics, sir. So any
Yes.
patient, if they come, if it is more than 12 hours of the chest pain or MI which they have come, then as a
No,
thrombolytics.
no use. No use. Why? See, whatever the damage, even we are counting the time in a second, not in the minutes. This is in hour. You understand? 12 hours. So
Yes,
after
sir.
12 hours, useless. I mean, whatever the damage to the myocardial infarction, say for example, again question in the exam you must be knowing. Let me take this that very quickly. These all are exam question. Anything they can ask. Like stroke patient, right? So
Yes, sir.
stroke patient 0 hours, 1 hour, 2 hour, 3 hour, 4 hour, 4.5 hours, and beyond 4.5 hours. So many guidelines says if you
Window.
have ischemic stroke, right? You have ischemic stroke. 3 hours is absolutely international recommended guideline. This is called as a golden hours. You understand, right? So
Yes,
any patient comes with the ischemic stroke, right? And you give the this TPA or tissue plasminogen antigen because of thrombosis or embolism. Two mechanism. Ischemia is either because of thrombosis or embolism, right? So in that case, if you give thrombolytic in golden heart, it's absolutely. There is a guideline up to 4.5 hours. It is also helpful. This is absolutely recommended world over. There is no discussion, no confusion. Up to 4.5 hours. But if some patient comes after 4.5 hours, then there is no rule. Why? Because whatever the neurons in the brain gets damaged, it's damaged forever. Right? Then you just give the aspirin. Go and read it. This is exam question. Hundreds of MCQs. Patient presented after 6 hours of hemiplegia, blah, blah, blah. There are hundreds of questions, right? But you need to know the basic things. Whatever they ask, you need to know the basic thing. Same patient develop acute MI up to 12 hours, you can give it. If you manage within 60 minutes, that is the word is mention is a door to needle. Needle is like you giving the injection intravenously something in the vein. In terms of thrombolytic, this is the best. If somebody comes at 120 minutes, you can give it, right? But the maximum advantage, right? Even if you can able to manage in 10 minutes, it would be even more better. But this is guideline.
Yes, sir. Sir,
You
if
got
the
it?
patient is going for PCI, then we don't give thrombolytics, no, sir.
No, in give in 100% not.
Okay, yes,
Mona, PCI. That's it. If you
yes.
don't have PCI, then
Then we,
Mona, thrombolytic, and then PCI. PCI you need to do na because when you have a block na. So how did you get to know the block without PCI? How did you get to know?
Hmm.
Probably patient has not a one block. Patient has a three block. Left coronary or left anterior descending, left circumference, right posterior, right coronary. You may be a four block. You never know. How did you get to know without doing the PCI? So PCI is 100% mandatory. So if you have no PCI, say for example, you have nice thrombolytic setup. So you give the Mona, you give the thrombolytic, streptokinase, urokinase, altiplase. After 12 hours or 6 hours, once patient is stabilized, send it for PCI. You need to do. Otherwise, patient in the evening again develops second MI
Yes, yes,
because
sir.
you
Got
don't know, no? You don't know where is the block, what is the block. So you need to open all block, right?
yes.
So first is absolutely globally accepted PCI. PCI is the best and biggest advantage is that There is a no contraindication apparently of doing PCI. Thrombolytic, there are long list of contraindication of thrombolytic. Again, our GI hemorrhage will come, a recent brain hemorrhage will come, platelet count of less than 20,000 will come, recent CPR given to the patient will come. So go and read that as your homework. Absolute, there are two contraindications: absolute contraindication, relative contraindication. Relative, where you can give, but relative contraindication, like patient has acute inferior wall MI and patient has a platelet count of 1 lakh or 100,000. Relative contraindication you can give, right? Because of the risk of bleeding, if you don't give patient, anyway he will die because of ventricular tachycardia or VTVF, he will die. You need to give. Absolute you cannot give. Relative you can give, but you need to know both what is relative, what is absolute. Is that clear to everyone? Yes or no? Tell me at least yes or no.
Yes, sir.
Excellent.
Yes, sir.
Excellent. I'm very glad. You are all intelligent. Wonderful. So now closing the lots of questions with acute MI. The answer of these questions avoided in this management. So what you want to avoid? You want to avoid the nitrates. Two things: less than 90 and sildenafil.
Good enough.
This patient is already in hypotension. Already in hypotension. If you give this become 60 blood pressure, and now you are giving patient now pressures. First you are reducing the pressure. Now you want to increase with the this noradrenaline and adrenaline and blah blah. You give all the things in ICU, what you do, or IABPs and all you do, right? So you don't need to do that, right? Just try to avoid. This is, it will not going to improve the overall survival of the patient, right? So you avoid, especially in hypotension or sildenafil. Is that clear to everyone? Yes or no?
Yes, sir.
Fine. So let's
Yes.
jump to the next couple of questions, little tricky and interesting. 74-year-old man with the history of chronic obstructive pulmonary disease, present with 3 days history of worsening of shortness of breath, wheeze, non-purulent cough with fever. He appears unwell and following blood results. WCC, this is white cell count or white blood cell is 13.8, little elevated. CRP 39 also elevated. PO2 49, that is lower than normal. Reference range is given in the bracket. PCO2 is 33, little less, it's fine. SpO2 is 95, 95 to 100. The most appropriate treatment is oxygen therapy, antibiotic therapy, physiotherapy, short acting bronchodilator therapy, intravenous theophylline. Take your own time, nothing urgent. I need three questions. In every question, those who are new joining first time to my class, I given this Munjal's triad, I given the name, diagnosis, investigation, and treatment. You must know for each MCQ three things. Ask yourself from today onward. Any MCQ. So this MCQ, three question. Another MCQ, three question. Another MCQ, three question. So I need to know first diagnosis. I need to know how you gonna investigate, and then I need to know. So in one MCQ, if you solve today 50 MCQ means you are solving 150. Why? Because you are trying to find out three answers: diagnosis, investigation, treatment. So 50 MCQ if you solve today, do this habit so you can solve 150. Go ahead, read the question, give me the three questions. Yeah, you can post your answer in the chat box. Yeah, post your answer. So far, I did not get any answer.
Not.
Yes, Dr. Lalita, I want to understand what exactly you want to give the antibiotic, which antibiotic you want to give. Yes, Lalita, you can start now. Dr. Nisha, also you can answer. Dr. Nisha.
So here the total count is elevated, CRP is elevated,
Okay.
and fever is also present. So I think patient is having infection also along with exacerbation of COPD.
Okay,
So
great. So
and
now let's
along with the bronchodilators.
fair enough. So so you have antibiotic in the option, you have bronchodilator in the option. What do you think? What is the main priority? So diagnosis is what, first of all? You can reply, no problem. You will learn something. And another advantage is when you discuss, you will never forget. That is additional advantage. Yes, tell me. What's the diagnosis here? You should not break this chain in any MCQ. Then you become, if you do this practice, now believe me, after 1 week, 10 days, 15 days, you are little more expert than before. Yes, Nisha.
COPD exacerbation because of
COPD
shortness of breath,
exacerbation.
breathing.
COPD exacerbation. You are absolutely right. Going absolutely brilliantly well. COPD exacerbation. Fair enough. Now, whenever you have COPD exacerbation, right, patient has a worsening shortness of breath. Wheezing is bad, non-purulent cough, and fever. These are the things, all right, with you. What do you think? What helps this patient the most? Antibiotic?
Bronchodilator.
What do you think? So answer is
But
bronchodilator. Answer is
broncho.
bronchodilator. Answer is bronchodilator. After bronchodilator, you probably give patient the saturation is normal. See, so it is not in a very severe bad thing. So
Yeah.
that is what initially it is not required. Initially not required. They had given all parameter, right?
Yeah.
Intravenous thiopylline takes lots of long time, long acting drugs not required. Physiotherapy at acute exacerbation will not help. For the prevention of recurrent infection, recurrent pneumonia, bronchiectasis, blah blah, chest physiotherapy is required. Now you have two options, right? This is how you need
Antibiotic. Yeah.
triage. Antibiotic versus bronchodilator. So this patient is in acute exacerbation. So first you give. If you are not giving the bronchodilator, patient may hamper with the oxygen tissue oxygenation, right? So you must give the bronchodilator first, and after
Okay.
bronchodilator, antibiotic, right? Without
Yes.
antibiotic, patient will not die. But if the continuously patient is in distress, he may go into the failure type 1 or 2, right? Can anyone tell me what is the difference between type 1 respiratory failure and type 2 respiratory failure? We usually try to avoid reading this topic. That is why I'm bringing is. Anyone open? Have you heard type 1 respiratory failure, type 2 respiratory failure?
Yes, sir.
What is that?
Type
Oxygenation.
1 is because of hypoxia, sir, and type 2 is because of more carbon dioxide. In that also, partial pressure of oxygen will be less, but partial pressure of oxygen, carbon dioxide will be increased in type 2. In type 1, it will be either normal or decreased.
Fair enough. So primary definition simply as you rightly doctor said, Dr. Ayesha, right?
Yes, sir.
Type 1 is a oxygen reduced, that is the term is called hypoxic. Hypoxia. Hypo means less and oxia means oxygen, less oxygen saturation, that is hypoxia. And this is
Capnia.
hypercapnia.
Yeah.
Hyper means high and capnia means carbon dioxide. So simple, no need to mug up. So hypoxia or hypercapnia. So it's a different. In hypoxia, if you supplement the oxygen inhalation to patient, it will help. Isn't it? Yes or no?
Yes, sir.
Here, not much help. Not much help because oxygen saturation is normal, but patient is in failure because of increased CO2 or hypercapnia. Can anyone tell me what are the causes clinically, which condition where you see the hypercapnia? Any condition or name of the disease where you say that this condition can cause hypercapnia?
Yes,
Heart
COPD
failure.
can cause
Sir, in
type
respiratory failures, Guillain-Barré syndrome, also asthma.
COPD, sir.
Severe asthma.
Great. So
Asthma.
there are lots of causes. Right. There are metabolic causes as well as respiratory causes. Let me tell you respiratory. One is a COPD, obviously, chronic obstruction,
Yeah.
right? Then cause asthma can cause, pneumonia can cause, pulmonary embolism can cause. If you look at the neuromuscular stroke can cause, right? Because they cannot breathe well. They cannot remove the carbon dioxide well from the chest. Sedative drug overdose, hypothyroidism, multiple sclerosis, amyotrophic lateral sclerosis, long list, flail chest, ankylosing spondylitis, right? And there is a long list, but you need to know little basic things what the day to day practice you can see and come across, right? So another homework, read, go and read two topic, go and read 110% patient question will come. What is ARDS? Second is respiratory failure, type 1 versus type 2, how you diagnose, how you investigate, how you treat. Same ARDS, how you diagnose, how you investigate, how you treat. That's it. So this is two homework from my side for today's, along with the earlier homework. So you just catch up that homework later on. Right. So type of respiratory failure, hypoxic respiratory failure, right? This is a hypoxic, oxygen saturation is low. That is the simplest definition. But if you go with the ABG, PaO2 is less than 60 millimeter of Hg, and hypercapnic respiratory failure where increased CO2, normal CO2 is 35 to 45, anything more than 50 is hypercapnic, right? And very rarely hypoxic and hypercapnic can occur together. So go a little bit read it, right? This is COPD, not going much in detail, right? So here the answer is a short-acting bronchodilator. Patient is suffering from the exacerbation of pre-existing COPD, and management should follow a stepwise approach. Increase frequency of bronchodilator, right, is the first line therapy to stabilize the patient and provide acute relief of the pain as well, right? So that's it. This is what the thing is. Rest of the things are also important. Let's come to little also important and little complex questions. Probably the last for today, then we'll discuss in the next. 68-year-old man comes to the physician for a follow-up examination. He has type 2 diabetes and hypertension and chronic kidney disease. Medication includes insulin, metoprolol, atorvastatin. Why? Because it's a dyslipidemia, diabetes, and hypertension. Physical examination shows pitting edema on both ankle. Serum creatinine is 4.5 milligram per dl. Which of the following sets of the serum finding is most likely in this patient? There are 4 block parathyroid or prothormone or parathyroid hormone, vitamin D, calcium, and phosphorus, right? Decrease, increase, 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 decrease, blah, 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 blah. You can see it, right? Little tricky questions, but I want to check your knowledge. Tried, first of all, diagnosis without diagnosis, 110% you cannot answer these questions was your, then investigation, and then treatment. Think over it. What could be the diagnosis? You think, I'm not in hurry. Think. Everything is there. Once I tell you, oh, sir, this is so easy, because I did practice for last 10 years and I'm doing this every day in my clinical patients as well. So I compile my patient's history, examination lab, blah, 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 and then I try to make one diagnosis by myself. What could be the diagnosis or differential diagnosis? Then I come to the specific diagnosis and then I jump to the treatment and patient is fine. Without diagnosis, nothing can happen. Yes. Anyone, open for all. You have you have done lots of easy question, but it's now time for little tricky as well, na? Every time in an exam you won't have lollipop questions. So try to prepare yourself for 20-30% toxic questions. 70% are reasonable, 30% are toxic. Yes, anyone, open for all, everyone, all brilliant. Anyone wants to comment anything, they can comment. First, forget about this now. I want to know the diagnosis first. Then this would be easy. Then it would be a crystal clear easy. It looks difficult to you now, but once I'll tell you, it would be easy. Yes, Lalit, any comment? Yes, any comment from the audience? Dr. Jamila, Dr. Nisa Lal, Dr. Aksa, Dr. Shakila, Rivindu, Safa, Aisha.
Sir, is a right heart failure?
Secondary
Sorry?
hyper.
Heart failure?
1 minute. Who told? Sorry, I'm just trying to understand. What's your name, doctor?
Minu.
Okay, so now, doctor, you tell me heart failure. You told the diagnosis or likely diagnosis. Now, tell me point favoring heart failure, point not favoring heart failure. This is another technique by which you can do excellent in your exam preparation. Whenever you give any answer, you give me the sir, these are the point favoring the heart failure. These are the point not favoring the heart failure. So now tell me what are the point favoring the heart failure in this scenario.
Pitting edema on the both angles?
Fine. So I'll write down pitting edema on the both ankle. Now in this, if I can tell you, this pitting edema cannot be seen in a renal failure whose creatinine is 4.5. Creatinine is 4.5.
Yes,
It
sir.
is very high. Normally 1 or 1.5. This is
Yes,
0.5. Still, you think this is a heart failure?
Diabetic and hypertension.
So diabetes and hypertension, that also can lead to chronic renal failure.
Chronic
Yes or
renal.
no?
Yes, sir.
Patient is already chronic kidney disease patient. Then what makes you to think of heart failure? I'm just trying to understand your concept. Heart failure patient, they also can have a hypertension, diabetes as a risk factor. It's possible. But creatinine is not increase in heart failure. Number two, when there is a heart failure, patient has a main complaint of shortness of breath, which is not there. Here the complaint is only just physical examination. Patient has a crackles or rails or crepitation. Patient has a low ejection fraction, especially in a systolic heart failure. Systolic heart failure, ejection fraction is low. Diastolic heart failure, ejection fraction is normal. If you don't know the difference, you go and read the heart failure. 110% question will come. This is not a patient of heart failure.
So it is a renal failure.
So this is a renal failure. So now we get to the diagnosis renal failure. Okay, fine. Let's discuss renal failure. What point favoring renal failure? What point not favoring the renal? Whatever the answer you give today onwards in your MCQ preparation, if you are doing alone, ask yourself what point favor in whole scenario, complete scenario. Whole means complete scenario. What point favor in whole
Serum
scenario? What
creatine
not?
concentration.
Creatine.
Creatine concentration.
So increase creatinine concentration. Fine. Increase creatinine, right? So renal failure, you told renal failure, right? That could be the reason in this patient. So increase creatinine, eventually reduce urine output, edema, pitting edema. Risk factor is hypertension and diabetes, commonest globally, isn't it? Yes or no?
Yes, sir.
Fine. So now probably the diagnosis is renal failure. Now in renal failure, what happens to this all four?
Renal failure, vitamin D will be
Causes
reduced
secondary hyperparathyroidism, sir, because of decreased vitamin D and calcium.
because kidney
Fine.
cannot absorb the vitamin D, sir.
Wonderful. So there are three type of uh, this hyperparathyroidism. Yes or no?
Yes, sir.
Yes.
Yeah. So because of kidney, it falls in which?
Secondary.
Primary, secondary, or third, tertiary?
Secondary, sir.
Secondary.
Secondary. So
Secondary.
cause, first of all, we can see the cause. So secondary chronic kidney disease. What is primary then? What condition can cause primary hyperparathyroidism?
Main defects of the parathyroid like adenoma or hyperplasia.
Okay, so I can say parathyroid adenoma,
So yes.
isn't it? Okay. So parathyroid adenoma usually present with primary hyperparathyroidism. Secondary we'll see gradually. So all concept clear. Secondary, third, tertiary. Anyone knows what can cause the tertiary as well? Like primary hyperparathyroidism,
Yes, yes.
parathyroid adenoma. Secondary is chronic renal failure or chronic kidney disease. What tertiary?
Um, it is parathyroid gland hyperplasia only, sir, because it become the autonomic gland. I mean, it doesn't come under control of anyone. Because of persistent CKD. I think this can be tertiary. Actually, this case can be tertiary, I think, sir.
Fair enough. So what I should write down here, doctor? What causes third?
Autonomic parathyroid hormone, chronic CKD, autonomic,
So
automaticity.
CKD is a chronic CKD, na? CKD, chronic kidney disease, that is CKD. Earlier name is CRF, chronic renal failure or chronic kidney disease.
Calcium.
Fair enough. Now tell me what happens in primary, 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 primary hyperthyroidism and secondary hyperparathyroidism, hyperparathyroidism, primary hyperparathyroidism. So primary versus secondary, one head-to-head comparison. What happens to PTH in both?
It will increase.
Primary is because of parathyroid gland itself is a problem, and here the likely kidney is a problem. Forget about tertiary now, primary and secondary. What happens to PTH?
Increased, sir.
Parathyroid hormone increase. What happens here? Secondary
Same, sir.
hyperparathyroidism.
Increased.
Is excellent, wonderful. One job is done. Second is a vitamin D. What happens to vitamin D? In primary, what happens in secondary?
In secondary,
Secondary, it will be reduced, sir.
secondary it is decreased, sir. In primary, it will be normal only.
Normal
In
or
secondary, it is reduced, or here you say normal.
normal.
Okay, third thing. What happens to calcium in primary hyperparathyroidism?
Calcium will be increased, sir, in primary.
Primary increase, then secondary what? Increase
Decreased.
or decrease?
It will be decreased or normal.
Decreased, sir.
Decrease. Okay. And last but not the least, phosphorus. What happens in primary? What happens in secondary?
Parathyroid hormone pees out the phosphorus, sir. So in primary, it will be less.
So phosphorus less. Here, less or normal or high?
It will be high, sir.
High, sir.
High, sir. Okay. Now you match something. What is matching this? So this is you told this is likely kidney disease, right? Because it's all matching this. So in kidney disease, it's in secondary. So now look at the options where PTH is high, where vitamin D is low, where the calcium is low, and where the phosphorus is high. Look at the options.
Sir, answer is B.
Hmm?
B.
B, sir.
Is it?
Yes.
Anyone? Now let's go to the literature. Your homework is to read the parathyroid. It's not that difficult. Hyperparathyroidism pathology, primary, secondary, tertiary. Primary means something wrong in the parathyroid. That is primary, obviously. Primary hypertension, right? Primary hypothyroidism, secondary hypothyroidism, tertiary hypothyroidism, quaternary hypothyroidism, blah blah. So primary means something wrong in the primary organ, that is primary, whether it is thyroid or parathyroid or liver or kidney or right? So hypertension, primary means something, secondary to long list, some other reason, right? Like primary hyperparathyroidism, primary parathyroid gland, secondary due to anything like that. So primary hyperfunctions of the parathyroid cells due to hyperplasia, either adenoma, it's a benign condition, right? Parathyroid adenoma or parathyroid carcinoma, it's a malignant. So it's a benign as well as malignant. Primary problem is where? In the parathyroid, not in the kidney. Is that clear so far? Yes or no?
Yes, sir.
Yes, sir.
It could be
Yes, sir.
associated with the multiple endocrine neoplasia. Go and read it. Man, there are three type 1, 2A, 2B, and 3, isn't it? So man, you read it. I mean, man 2, sorry, not 3. Man 1, man 2 is 2 and 2B. So you go and read it. The hyperparathyroidism is one of the man. Calcium is high, obviously, no need to mug up. When there is a parathyroid hormone, right? There are four glands of parathyroid behind the thyroid. This is thyroid gland, and on the back of the thyroid, there are two pairs of parathyroid gland. Total number is four. It is on the back of the thyroid. You cannot see from the front, back of the thyroid. So this two pair parathyroid gland, the main parathyroid, the hormone is prothormone or parathyroid hormone. Para means parallel to thyroid, parallel to thyroid. That is how the name comes. Parallel to thyroid, parathyroid. It's a gland, it's an endocrine gland. So parathyroid secreted the prothormone. Primary function of the prothormone is to increase serum calcium level. Is that clear? Yes or no?
Yes, sir.
Physiology. So when primary calcium will increase, this is the biggest difference. So you must look at the calcium level, right? And always calcium to phosphorus is reverse ratio, high phosphorus calcium, low phosphorus. Management, usually surgery. Why? Because there is a problem in the thyroid. Parathyroid gland is enlarged. There is a tumor in the parathyroid. So you need to remove that tumor. That's it. That is what the treatment is. Surgical removal of hyperfunctioning parathyroid or parathyroid adenoma or parathyroid carcinoma. Is that clear? Yes or no?
Yes, sir.
Yes, sir.
Right? So this is what the thing is. This is primary. So what happens in primary? Concluding our talk, increase parathyroid hormone or increase POTH hormone, increase calcium, reduce phosphorus. Let's come to the secondary. Physiological stimulation of parathyroid in response to hypocalcemia. So when there is a hypocalcemia occur in body because of any reason, there is no problem in the parathyroid gland. There is a problem in the calcium. So when the body's calcium is low, what the brain and gland is thinking, I need to produce more calcium. And because of that, right, what happens? Usually due to chronic renal failure or other causes of vitamin D. So vitamin D less, calcium is less, right? In absence of vitamin D, calcium not get absorbed. If you go and read the physiology or vitamin D deficiency chapter, right? So either because of chronic renal failure, hypocalcemia, or because of vitamin D deficiency, there is a this hypocalcemia. In response to that, physiological stimulation of the parathyroid gland in response to hypocalcemia, right? So what happened? Calcium is obviously low, that is why this mechanism happens, physiological response, right? But definitely not high. So this is differentiating point. Here low, this is high. Treatment of underlying causes. They have not mentioned surgery. Why not surgery? Here surgery because there is a adenoma of parathyroid gland, carcinoma of parathyroid gland. So you need to remove that, right? That is surgery. Here not a surgery. Why? Because it could be because of chronic renal failure. So what surgery will do in chronic renal failure? Nothing. You just improve the chronic renal failure. Treat the underlying cause, right? And tertiary, following the long-term physiological stimulation leading to hyperplasia. So this is little different mechanism, long term, right? Long term physiological stimulation leading to hyperplasia of what gland? Parathyroid gland. Again, this is seen, right? So in renal failure, when they progress the renal failure, right, over a period of time, long term, it eventually hyperparathyroid or thyroid gets hyperplasia. Parathyroid gland gets hyperplasia because of chronic hypocalcemia, right? Gland thinks that I need to make more, right? Seen usually. So this is also in serum chronic renal failure that can also be seen, but here additional is vitamin D deficiency as well. The difference here is the calcium is high. Now because parathyroid is in action, so same here, whatever the parathyroid was making in primary, same thing in the secondary. So calcium is, at least calcium is increased, right? But the biggest difference is the phosphorus. Phosphorus in primary is absolutely low, while in tertiary is high. Usually synalset or surgery in those who do not respond. So first you give the drug which can reduces, but if no response, again parathyroid culprit, go for the surgery. Is that clear? Yes or no?
Yes, sir.
Yes.
Right. So you, it's little complex, but not that difficult after my explanation. So you go and read it. It's all with you now. I will share this PowerPoint as well. Don't worry. Right. So hyperparathyroidism is characterized by abnormally high parathyroid hormone level in the blood due to parathyroid gland overactivity. This is primary. Huh? So here let's directly jump to the answer. So CKD is answer is B. Everybody said correct answer. Answer is B. CKD is associated with vitamin D deficiency due to decreased 1 alpha hydroxylase activity by reducing the interstitial absorption of calcium. In absence of vitamin D, calcium not get absorbed. So absorption of calcium, vitamin D deficiency can cause low calcium level. So vitamin D is low, calcium is low, chronic renal failure. In that response, it stimulates the secretion of PTH leading to secondary hyperparathyroidism. Although high level of PTH normally stimulate the renal absorption of calcium and excretion of the phosphate, and phosphate excretion is impaired in CKD, resulting instead of hyperphosphatemia. Other laboratory abnormalities in patient with CKD includes hyperkalemia and metabolic acidosis, blah blah. So now if you read this scenario properly and fix the mind in your head about the chronic renal failure patient comes, now what do you think what it could be now? Now picture is more clear. What is the answer? A, B, C, D or E?
B.
Yes, that's correct. Why? Because it is a hyperparathyroidism, so growth hormone is increased, right? Here the difference is in primary calcium is increased, here calcium is decreased, right? Vitamin D is low in CKD, that is why calcium is not get absorbed. It is also low, and there is a hyperphosphatemia. That's it. If both are high, then it is tertiary. If both are high, then it is tertiary. Is that clear? So I think that's all from my side for today. Thank you very much all for listening me coolly and calmly. Though we discuss only 5 questions or so, but I think we discussed 50 questions at least by my sense. So thank you very much once again. I would like to have a quick feedback on the sessions. How did you enjoy it, learn something new, or how was your experience in last 1 hour and 45 minutes? Anyone, please. Yes, please. I would be glad so I can improve myself for more. Yes. Any comment?
Very nice, sir. I mean, you got all the questions. It was, although it was just one question, but you linked it with so many questions that, the entire topic got covered. And it's like revising, really having a patient in front of us, and we are deciding what to manage. It was very nice presentation, so thank you.
Wonderful. Excellent. Thank you very much for your kind feedback, Dr. Aisha. Yes, anyone? Solomon, Sukhdeep Singh, Santosh, Safa, Sakila.
Sir, it is a good presentation, sir. And
So, did you learn anything new which you never thought of earlier, or something got more concept cleared, or you feel that this is the way you supposed to prepare in your exam, something like that?
Yes, sir, of course.
yes, sir.
Sorry.
Yes, sir. The thought process of approaching the case is excellent in your, presentation as always. We never thought that we can think in that way as well. Like morphine, we every day we use it, but
Yeah, that's correct.
but today only we got to know
Well,
that what is the actual role of morphine.
yeah, I mean, we enjoy, no? When we know why we are giving it, then we really enjoy, right? When I'm giving some hematology treatment, being hematologist to patient, I enjoy. Why? Because I know why I'm giving this.
Exactly.
You understand?
Yes, sir.
So you enjoy. Yeah, great. But I think this, my technique probably helps you as well, because this is how I prepared myself in my clinic. Says tomorrow is a big OPD for me, right? So I'll not monotonously, robotically work in my OPD. I'll try to understand, okay, fine, this patient, 50 years of male, this much of comorbidity, this is the chief complaint, abdominal pain, what's the in USG CT scan, what's my differential, then I'll proceed. You understand? So that
Yes.
makes some impression in your mind, and it will not just for the MCQ point of view, will make you a good clinician by my experience.
Yes, sir. Even the hardest topic become easy the way you explained it.
Thank you very much for this nice compliment. But I think this is what I'm sharing, my experience, nothing else. Everything is in the book. I did not bring it anything from out of the way. Little MCQ I compiled and tried to format it nicely for better presentation. But but it's all in the book anyway. But you need to concentrate on the specific things, and we try to avoid the weaker points. So I request everyone, don't ignore the weaker points. Try to do it. Hyperparathyroidism. Again, you don't understand primary, secondary, tertiary, go and read it 2 times, 3 times. You never know what question comes from it. 100% it will come, right? But we try to avoid. We try to avoid the understanding how you differentiate against thyroid. 90% people may not know what is the cause of quaternary hypothyroidism. You probably don't know. So primary hypothyroidism, secondary hypothyroidism, tertiary hypothyroidism, and there is a term quaternary hypothyroidism as well. So go and read it. I mean, it's a common questions comes in the exam. They won't ask you very hi-fi radio iodine uptake assay study or thyroid scan. Won't usually ask you. They ask you the basic, how you differentiate hypo from hyper, what is Hashimoto's disease, right? What is myxedema? Simple question, but probably we don't have the concept clarity of myxedema. We learn, we know 100 times, but we don't know what is the treatment of myxedema. Just, I mean, trying to give you the general idea. So you go and read it. So once again, thank you very much those who have given the feedback. Anyone last 1 more minute if somebody wants to comment on these things? Sakila, Solomon, Sukhdev, Rividu, Aksa. Fine, fair enough. So thank you very much once again, and we'll see you
Thank
in
you
the
so
next
much, sir.
class.
Thank you
Thank
so
you
much.
very
Thank you,
much.
sir.
Take care. Bye bye. Bye bye. Bye bye.
Bye,
Bye.
sir.
Take care. Bye.